So today we are going to read organophosphorus poisoning. So basically what we are going to read in this organophosphorus poisoning topic is, first we will see the introduction of the topic, then we will see the classification of organophosphorus poisons, then we'll see the absorption, how it get absorbed in the body, then we'll see signs and symptoms of organophosphorus poisoning, then we'll see what is the cause of the death in OPC poisoning, then we'll see how we are going to diagnose it, then we'll see what are the viscera that we are going to take for chemical analysis to confirm our diagnosis, then at the end we'll see the treatment, and then we'll see the post-mortem appearance. So we'll see the introduction. So what is organophosphorus poison? So it is widely used insecticide throughout the world. Fine, it is anticholinergic esterase agent and it can be used in wars and all also, and the therapeutic uses in the treatment of the glaucoma. So it is basically used in pesticides in the commercial agriculture and all those things. Fine. Now like it have immense benefits for the mankind, improvement for the crop production, thus helped in increase the economic and living standards for many countries all over the world, and it plays a major role in green revolution to increase the health of the plants and everything, like it is used in agriculture. So this is some of the history of organophosphorus poison. So the research in the field of organophosphate started after the First World War to find out a potent poison to use in warfare for killing human beings. So this was the history, like basically that's why organophosphates were originated. Then we have classification of organophosphates. So one is reversible, then is irreversible. So this is a chemical structure basically. One aryl or alkyl group will be there, then oxygen sulfur group will be there. This is like your choice if you want to remember this basic diagram. Then we have alkyl phosphates. These are some of the examples of alkyl phosphates. So the most important is malathion. If you're having some clinical question also, they will be telling that malathion used by some agriculture person and then he came with symptoms of this that I'm going to tell you later on. So if you want to remember, you can remember HETP, that is hexaethyl tetraphosphate, but malathion is must, you have to remember that. Then we have aryl phosphate, that parathion you have to remember in this. Other things if you want to remember, you can remember, no issue. Then absorption, how basically organophosphates are absorbed in my body. So basically it is mostly absorbed through the skin or mucous membrane, gastrointestinal tract also, or by inhalation. So now we'll see the action of organophosphates. So what basically happens is organophosphates are acetylcholine esterase inhibitor. So as all of us know, that acetylcholine esterase is the enzyme present in RBC, neuromuscular junction, and usually in brain also. So let me take example of neuromuscular junction. In neuromuscular junction, no, what happens is acetylcholine will be there. Acetylcholine esterase comes and it binds to acetylcholine and break it into acetic acid and choline. But now what is happening? Organophosphates are there, so it will go and bind to acetylcholine esterase and inhibit it. Now acetylcholine is not going to break into acetic acid and choline, so there will be more accumulation of acetylcholine, right? So basically organophosphate compounds inactivate the enzyme and acetylcholine will accumulate in the body. This is what happens in organophosphate poisoning. And then this is the diagram. You can understand from this what happens usually and then what happens in organophosphate poisonings actually. Then the signs and symptoms of organophosphates are due to overdose of acetylcholine in the body. Fine. We have two sides, esteric side and anionic side. So organophosphates, what they do, they will go and bind to esteric side and inhibit it. Fine. Initially binding is like usually not that strong. It is due to hydrostatic attraction only and it is reversible. Firm binding at the site occurs when hydrogen ion is reversed from the system and reaction becomes irreversible. This is the diagram, not so important. It was given in the textbook, that's why I mentioned it here. The antidote oximes can act to dephosphorylate only before firm binding. So basically that is within 24 hours if you are giving oximes, that I'll teach you in the treatment part that oximes and atropines are given for organophosphate poisoning. So oximes should be given as early as possible. Fine. These are some of the signs and symptoms of OPC poisoning. The clinical manifestation of organophosphates are due to toxic action of acetylcholine that I told you earlier also. They can be categorized into muscarinic effects, nicotinic effects, central nervous system manifestations. So most important is muscarinic action only, that you have to remember, no doubt. It is due to increased postganglionic parasympathetic stimulation. Fine, it usually affects pupil, glands, urinary bladder, cardiac sinus node. And these are some of the clinical features you can remember by the mnemonic sludge. So salivation, lacrimation, urination, defecation, gastrointestinal distress, emesis. And then this is the diagram you can see, because photogenic memory is always the best one. You can remember in the exam. If you remember in the exam the diagram, pictures, so you can write also. And this is another mnemonic dumbbell if you want to remember, like diarrhea, urination. These are some of the clinical features of organophosphate. Then nicotinic action is due to preganglionic sympathetic stimulation and action at the neuromuscular junction. They are muscles. Muscles will be having twitching, cramps, fatigue. Patients will be, eyelids will be having twitching, tongue and twitching can also be there in the facial muscles as well. Fasciculations can be seen in skeletal muscles as well. Cardiovascular system, what are tachycardia will be there, sympathetic stimulation, hypertension can also be there. Then this is another diagram if you want to remember by the diagram. This is cholinergic toxidrome. If you want to remember, this is the same things. By the sludge, you can remember the muscarinic symptoms, the nicotinic symptoms are sideways. CNS manifestations, all the CNS manifestations you can find: confusion, drowsiness, convulsions, coma, depression, respiratory centers will be depressed. So basically, death happens due to suppression of the respiratory center, that is respiratory failure. So this is the diagram again if you want to remember in a nice way. Then again, just summarizing the clinical features of organophosphate poisoning, again the same thing. Then phases of OPC poisoning, what happens initially, then later. Then there are 3 phases of OPC poisoning. First is acute cholinergic phase, then intermediate phase, then delayed polyneuropathy. In type 1 paralysis, acute paralysis, what is happening starts within few minutes of exposure due to persistence depolarization at neuromuscular junction and blocks acetylcholinesterase. Signs and symptoms are fasciculation, cramps, weakness, paralysis of respiratory muscles. Patient respond to atropine in this phase. Phase 2 is usually happens after 2 to 3 days of acute cholinergic symptoms. This may be due to neuromuscular transmission defect, toxin induced, it can be. Then signs and symptoms, there may be weakness of proximal limb muscles, neck flexors and respiratory muscles, cranial nerve palsy can also be there. And in this stage, person do not respond to atropine or oximes. Late stage delayed polyneuropathy obviously usually happen after 1 to 4 weeks after the exposure of OPC. Paralysis of lower extremities, foot drop, numbness. It may gradually progress to upper extremities. Fine. And patient may have numbness and paresthesia. Cause of death in OPC poisoning, I told you earlier also, and it is due to respiratory failure by the depression of respiratory center. Fine. In addition to this, there may be paralysis of respiratory muscles and bronchospasm due to direct action of acetylcholine at these sites that I also told you earlier. Diagnosis, basically now it is important how you're going to diagnose a patient of OPC poisoning. So basically first is cholinesterase activity you have to see. Diagnosis can be made by estimation of acetylcholinesterase activity. Normal value is 77 to 142 of true cholinesterase. Cholinesterase activity reduced by 22% to 88% in organophosphorus poisoning. Fine. Then chemical analysis we can do by organophosphates can be detected in the blood by chemical analysis using thin layer chromatography or liquid gas chromatography. Next is nitrophenol estimation in urine, diagnostic of parathion poisoning actually. This is also very important. They also ask in Viva that what are the usual viscera taken for chemical analysis. So you have to remember the stomach and its content, small intestine 30 centimeter, liver 500 gram, half of each kidney, then blood 30 ml taken, urine 30 ml taken, NaCl can also be taken, or spirit, that is for preservation. Then treatment part is generally what we are going to do: wash the body with soap and water to prevent cutaneous absorption of the poison. Then if eyes are contaminated, they should be irrigated. The airway should be kept patent. Endotracheal incubation or tracheostomy may be needed. If there is cyanosis, oxygen should be given. Then stomach wash should be done. When the poison is ingested in the stomach, it should be washed with 1 into 1000 potassium permanganate solution. Activated charcoal can be given through the stomach wash tube. Fine. Then this is the another treatment. Atropine sulfate is given, reverses the effect of acetylcholine. Fine. It acts as the physiological antidote, reverses mainly the muscarinic effects of acetylcholine at the muscarinic receptors. So the parasympathetic effects are reduced. It does not bind to nicotinic receptors and hence no action on neuromuscular junctions. This is the dose actually. I don't think this is much important at the MBBS level at least. So 2 to 4 mg every 10 to 15 minutes is given till the signs of atropinization appear. That is dilatation of the pupil and decrease in secretions. Another thing is we can use the oximes also as the treatment. These are the specific antidotes. These are some of the examples of oximes. If you want to remember, you can remember. Basically, what is its action? It reacts with phosphate moiety of organophosphate and acetylcholinesterase complex and gets phosphorylated. So acetylcholine is released from the complex. Thus, reactivation of the acetylcholinesterase will be there. The oximes decrease the muscarinic, nicotinic and CNS effects of organophosphates within 10 to 40 minutes. Given as early as possible before the organophosphates acetylcholine complex becomes irreversible. No benefits will be there even if given after 48 hours. This is some of the doses. If you want to remember, you can remember. Not so important. Side effects of oximes is side effects are mild. Rapid administration may cause dizziness, headache, blurring of vision, nausea and tachycardia. These are the postmortem findings. So basically how we are going to see a patient of organophosphorus poisoning. Externally, there will be kerosene-like smell from the nostril and mouth, cyanosis of the lips, nose and finger. Deep postmortem staining will be there, congested face will be there, blood-stained frothy discharge from nose and mouth will be there. Then what are the internal findings? Mucosa of stomach and intestine is congested. Stomach contents may give kerosene-like smell. Edematous respiratory passage may also contain frothy hemorrhagic exudate. Edema and congestion of lungs, brain edema, heart will be soft and flabby. This is the autopsy finding. Then medical legal aspects of organophosphorus poisoning. Usually it is asked in forensics. So accidental poisoning can occur in spraying, the people who used to spray, right, insecticides in the agriculture. So accidental poisoning can happen. It can also happen in children and all. Suicide with this poison is usually common, and homicide is usually rare. Incidents of homicide by mixing the compound with alcohol or other soft drinks have been reported. Hospitalization of all symptomatic patients for 4 to 6 days is necessary. And then these were the references that I took. And then thank you so much. And the slides will be attached in the description. So if you want to see the slides, you can go and check the description, and you can note down the notes if you want to take. And so thank you so much.